Hello, good afternoon, good morning, and good evening, everyone from wherever you are. Thank you for joining our LabCoP session for August 2021. My name is Anafi Mataka. I'm the program manager for the LabCoP. And as usual, I'm delighted to be your host today. Today, we are looking at a very important topic, the topic of HIV viral load scale-up. And it is an opportunity that we have got today to try and review what really has been happening from when the initial WHO recommendations were published in 2013 up to present. And to do that, we are honored to host Dr. Shirley Lecher from the CDC International Lab Branch, who's going to take us through the presentation today. This session, as usual, will be 1 hour long, where we shall start with the presentation, following which we will take questions and comments from the audience. Please keep your comments and questions coming through the chat, and we'll attend to them after the presentation. I would like to remind you that we do have simultaneous language interpretation from English to French. So kindly choose the language of your choice. To find the button for interpretation, you go to the bottom right of your screen if you are using a desktop or laptop, and click on the icon for the globe, and then you should be able to choose the language. Ladies and gentlemen, allow me to hand you over to our presenter today, Dr. Lecher. Over to you, Shirley.
Good morning, good afternoon, good evening, everyone. So it's a pleasure to be here with you and share with you the results of this analysis, looking at 8 countries from the beginning of scale up through the end of 2018. Acceleration of viral load testing has been a global priority, as we know, following the release of the WHO guidelines in 2013, which recommended using viral load to monitor patients on ART, and that was followed in 2016 by ART guidelines that recommended viral load testing for all HIV positive persons. These guidelines promote the UNAIDS goal, it's the PEPFAR goal, it's ASLM's goal, it's all of our goal to help end this HIV epidemic by 2030, with 95% of patients receiving ART having viral load suppression by 2030. Global ART expansion has increased demand for viral load monitoring. In 2018, there were 23.3 million persons receiving ART, which was an increase of nearly 200% compared with 8 million in 2010. The purpose of this, as Anafi mentioned, was to look at how far had we come since the beginning and since those guidelines came out for countries. And the country selection in this case, it wasn't that we specifically handpicked some countries over other countries, but we had an approved protocol for PEPFAR priority countries. And among those countries were Cote d'Ivoire, Kenya, Uganda, Tanzania, Lesotho, Malawi, Namibia, and South Africa. And so based on the fact that we had a previously approved protocol for these particular countries, and it would be a greater challenge to get clearance for a lot more, we picked these 8 countries to move forward with. And we also have strong relationships with these countries. Data were collected by the CDC laboratory advisors in collaboration with ministries of health from the laboratory information system on cumulative number of patients on ART, the number of patients on ART with greater than or equal to 1 viral load test, and percent of viral load results that showed viral suppression defined as less than 1,000 copies. We use country data for this rather than PEPFAR data. The reason for this is that in some countries, PEPFAR does not cover the entire country or all the labs, and we wanted data that was representative of the entire country. A full calendar year was used for reporting. which is from January 1st to December 31st, rather than the US government fiscal year, which is based on an October to September, end of September cycle. Country guidelines that were followed, everyone followed the WHO guidelines, except for Malawi at the time, which is 6 months after ART initiation, followed by testing at 12 months and annually thereafter. Malawi at the time of this data collection was doing viral load testing due to capacity issues every 2 years. They now are also following the same WHO guidance, but at this during the time of this report, it was every 2 years. So looking at the countries and the pre-scale up versus the scale up period from the WHO recommendations in 2013, for these countries, all but 2 started scale up in 2014. Côte d'Ivoire and Tanzania started a year later. And the period I mentioned. For Tanzania and South Africa, we had some challenges getting full year data for 2018. So the analysis for those stopped mid-year 2018 at the end of the first 6 months. So pre-scale up period, you can see that we had for Côte d'Ivoire, 129,993 tests going to over 248,000. For Kenya, 631,500 going to over 1,069,000. Lesotho, 111,322 going to 218,493. Malawi, 472,865 going to 805,323. Namibia, 126,779 going to 180,584. Uganda, 507,663 to over 1,167,000. Tanzania, 600,000, nearly 601,000, going to almost 1,999,628. And for South Africa, 2,609,275 to 4,551,000. For South Africa and for Namibia, those countries were doing more limited testing than the other countries that just started, and we'll see the trajectory in a second, but that's the reason for their larger numbers to start out with. The average interval from collection to return of results, we looked at turnaround time, wanted to know how long is it taking countries from when that specimen is collected to when that result is returned back to the facility. And when you look here, you can see it's variable in terms of the change. We had improvement over time for some countries, but for others, not so much. So for Côte d'Ivoire, we actually increased 50% that time interval. For Kenya, there was a 56% decrease in the time interval from 18 days to 8 days. For Lesotho, 56 days initially going to 28, which was a 50% improvement. Malawi stayed much the same at 18 days. Namibia, about the same, 5 to 6 days. Uganda went from 18 days to 14 days, which was an improvement of 22%. Tanzania, from 10 days to 27 days. South Africa, from 3 to 4, so largely unchanged. Looking at the percent, of on ART who had viral load suppression less than 1,000 copies, we had significant improvement over time for most. For Côte d'Ivoire, initially at 66% to going to 78%. Kenya, 64% going to 90%, Lesotho, 75 going to 93, Malawi, 86%, staying about the same, Namibia going from 74 to 94%. Uganda from 90%, about unchanged. I'd say the 2% is relatively the same. Tanzania going from 80 to 85%, and South Africa 75 to 85%. So in general, we saw significant improvement, and you can see that during this time period, 3 countries reached 90 or above. So they hit the last 90 of at that time, trying to get to the third 90. So this is a line graph that goes through the end of 17 for all the countries. As I mentioned, I didn't have the data for the second half of the calendar year for 2018. So this plot is to represent all of them. You can see for the vast increase in the number of patients on ART who got a viral load. The 2 countries up in the higher up, which are Namibia and South Africa, were doing some limited targeted testing. South Africa had been doing testing for about 10 years, but it was limited. And so that's the reason for those higher there. So this is a bar graph for the 6 countries that we did have data for, and there were huge increases, as you can see from this, showing where countries started and the percent improvement in scale up. And this figure shows the percent increase for viral load scale up for viral suppression. And here you can clearly see that most countries improved. In the case of Malawi, you can see it stayed the same, but we see improvement in all countries. The Uganda had a 2% change, and I'd say that was about the same. I wouldn't say that was significant. So how did countries accomplish scale up for viral load testing? It required sustained engagement between international partners and ministries of health. Efficiencies needed to be improved, and we had improvement in efficiencies throughout the viral load cascade. We had community engagement with civil society, which helped with demand creation. And we developed strategies for improvement in specimen transport that were implemented, and we had huge improvement in specimen transport. Training of multiple cadres was an absolute must. Healthcare workers for specimen collection and working with the clients as we scaled up. Laboratorians for specimen processing and viral load testing. Data personnel for data entry, collection, and transmission. And clients also receive training for demand creation and requesting results. LIS systems were installed or updated, and dashboards for many countries were created. For platforms, early in viral load scale-up, countries were procuring platforms directly from manufacturers, and we began to see a lot of issues with that direct procurement, particularly when we had issues with equipment breakdown and maintenance of the instrument. So those issues, inability to replace obsolete models, and difficulty trying to repair them, and high costs led to negotiations with manufacturers for reagent rental pricing and maintenance contracts, allowing countries to expand capacity without incurring unnecessary cost. In addition, deployment of point of care and near point of care platforms have expanded capacity and helped to reduce turnaround time. So what are some of the challenges that we faced then, and those challenges we are still facing now, particularly in light of COVID-19 and the challenges that we all have faced in all of our countries tackling this pandemic. Human capacity shortages sufficient for molecular testing for HIV, and for now we have the issue for not just viral load, but SARS-CoV-2. Some of the task shifting that has occurred presents an ongoing challenge. When COVID came to be a problem, many of our laboratorians had to stop doing viral load testing or do viral load testing and COVID testing because the same platforms are used and the capacity was not there. Improving efficiencies such as diagnostic optimization is needed for viral load and for outbreak response for COVID-19 and other pathogens for current and future epidemics. Laboratory information systems require optimizing. We have still challenges with procurement and logistics systems and linkage of data through dashboard that's needed for not just for HIV, but also for SARS-CoV-2 and current other outbreaks, whether it be Ebola or another pathogen and emerging pathogens. So viral load in the context of SARS-CoV-2, I'm not presenting data here for that, but to say that looking at what happened with viral load coverage during the pandemic, initially viral load coverage decreased for PEPFAR countries and the adult population. Looking at aggregate data, we were at the last quarter of 2019, we were at 78%, and we dropped down to something close to 72%. That's looking at aggregate data for 50 PEPFAR countries. And then we had improvement after the lockdowns were and other restrictions were eased and leveled off somewhere in the 72 to 74% viral load coverage range. Viral load suppression remained fairly stable. In recent months, this year has begun to increase slightly by 1 or 2%. In the pediatric population, and I separated that out from the adults, we see something different. Some countries did not actually have decreases. Some countries had increases in viral load coverage for different age bands in the pediatric population. So it was variable for countries. It was not, did not follow the same pattern or has not followed the same pattern as for adults. Of the 8 countries that were presented in this analysis, viral load coverage over the past year has shown some improvement for 6 countries. And we have a decrease, that means starting from pre-pandemic to now, and we have a decrease in 2 countries, particularly South Africa and Lesotho. The southernmost countries have been very hard hit by the pandemic and are in a state now of some degree of lockdown, which is causing challenges. In conclusion, viral load scale-up has been successful regardless of challenges faced during the process, with some countries surpassing the third 90 by the end of 2018, moving toward 90, the third 95. Countries have continuously built and strengthened systems to progressively scale up viral load each year. It's a high percentage of viral load suppression, greater than 80%, was achieved for all but 1 country, and that was Cote d'Ivoire, and they did demonstrate improvement. 3 countries, Kenya, Lesotho, and Namibia, achieved greater than 90% viral load suppression. Maintaining gains or viral load testing while also meeting the challenges of COVID-19 and preventing supply chain interruptions is going to be something that we are still challenged and working on. Viral load test result turnaround time decreased substantially in only 3 countries, Kenya, Lesotho, and Uganda. The turnaround time increased in Cote d'Ivoire and Tanzania, highlighting the need for increased efficiency. Other countries' turnaround time remained stable. The increased turnaround time could be explained by multiple factors: increased testing volume and the inability of existing systems to meet this demand, an increased number of facilities or service delivery points collecting specimens, leading to a more complex transport network, prolonged sample storage times until pickup at facilities or hub sites, or inadequate number of personnel to process the increased number of specimens at viral load laboratories. Continued capacity building is needed to address these issues. To overcome the remaining challenges, targeted interventions informed by data are needed to ensure that all patients receiving ART receive viral load monitoring. Effective partnerships between ministries of health and multiple international stakeholders, such as PEPFAR, ASLM, Global Fund, WHO, CHI, and others have contributed to progress in viral load monitoring. Ongoing engagement with ministries of health and finance and with other officials in financial and technical areas at national, subnational, and community levels will be required to sustain and improve current gains. And that's the end.
Thank you very much, Shirley, for the wonderful presentation, quite informative and also very encouraging indeed in terms of what we are seeing within the region, although it's most PEPFAR countries, but they do represent what is happening, particularly in the sub-Saharan region, that indeed viral load scale up in sub-Saharan Africa has improved significantly for the past couple of years. So that's good news, really. We also pointed that barriers do persist, and we need to continue, taking some of those patient approaches that you mentioned to address them. A number of methods, a number of solutions, technologies, specimens. You mentioned also the issue of point of care coming through, issues of maybe DBS, that also comes to my mind, that could have also contributed to this. And something that also keeps on coming to my mind is as we increase this access to testing and how much of the utilization is there. And it's also encouraging to see that some of the countries, I think you mentioned 3 countries really reaching the third 90. Of course, we are working to the 95, 95, 95. So we are also seeing quite those improvements. But of course, what we all know, COVID-19 has come and it's really threatening the gains that we have already amassed. So it's time for questions. They are really now pouring in. So we'll try to take some of the earlier ones as these are coming. So keep the questions and your comments coming through. Let me take this first one that came from, is it from Collins or Pascal? Yes. So where she is saying, are the numbers collected for the turnaround time coming from all facilities performing viral load, or these were a few selected labs?
So it was aggregate data. So we took all the labs and averaged it. So it's an average of all the labs. So you look at some countries, like for instance, Uganda, that has a dashboard. Most of their, this 5 days is like that, but you saw much longer because they're further out regions where they don't have that access to the dashboard and still relying on transmission of results back from the testing facility to the collection site. And right.
Thank you very much, Shirley. And as you were just talking about the COVID-19, Colin says the pandemic may have resulted in less testing. What is it that will be needed to ensure we regain the Firelord testing numbers for COVID-19?
So it appears that right now, when I just took a look at some of the PEPFAR data yesterday, that most countries have figured out a way forward by now. If we were having this conversation last year when we had all of these test results, the situation was dramatically different. Countries were struggling. We had some countries that weren't doing any viral load testing at all for periods. We had all the task shifting and so forth. But now the viral load coverage has come back up. And so I would say that we have figured out now what we need to do to try to optimize systems and make this work. There had to be hiring of more personnel, because obviously if everybody is maxed out just testing for viral load testing, then we couldn't do the SARS-CoV-2 testing. So the challenges are huge. Some of the things that have been done to improve access, in one country's instance, they have engaged community and they have set up ART dispensing in community pharmacies. And when you come to get your medications, you get your viral load test at the same time. So whether it's collection of DBS or whether it's collection of plasma, it happens. And so that community engagement has become a huge piece to help improve things when there are restrictions. We had closure of healthcare facilities, as you know, and so people still need to be serviced. So I think now, we have figured out that way forward, and that's why now we have seen, looking at the aggregate data for PEPFAR countries, we had the dip, but we're now coming back up to where we were pre. Not quite there in some countries because we had this another wave of COVID happening. So we are dealing with those challenges, but we have seen significant gains since the large dip from last year. So strengthening the systems that we have, community engagement, multi-month dispensing, those kinds of things have really helped out.
Thank you, Shirley. Indeed, I think you covered so many important topics there, and central to all those is the workforce that is actually involved there. And moving on, I would like to take this question from O'Brien Nalubanda, and I want to link it to one of the successes / challenges that you talked about in terms of data collection. He says, I've seen that from Southern Africa, Zambia is included. I assume he's from Zambia, he or she from, yeah, he's from Zambia. Did you have challenges in collecting data from ministries of health?
The simple answer is yes. It took the collection of that information took months, many months, and I would say thanks so much to our ministries of health who helped provide, some of whom I see are on this call now. And thanks so much to our laboratory advisors. It did require close collaboration and a lot of effort to get total data for countries, yes. And as you could see that even in the end, the last 6 months for 2 countries, in spite of efforts, it wasn't that people weren't trying to get that information, it's just that it was a big, huge challenge. This is the third and last report like this. We did one, as you know, back in, I think it was 2015, followed by one that in the following year. And so now we can see the huge success that we have made. And I think it was important to look back, but challenges in data collection still exist. I will say this, we have seen huge improvements in the data that now is available from countries. It's far more accurate than what it used to be at the first couple of years. And it's less challenging now than it was some years ago. So hats off to those who collect that data and get it into the dashboards for countries that have it are tremendously helpful.
Thank you, Shirley. I could see a big smile when you said there's a huge improvement in data collection. Indeed, I think things are keeping on improving. And although data still continues to be a challenge, which is one of the reasons why we now have a sub-community of practice on M&E, we continue to recognize that we still not able to collect some of the data points at national level. Our LabCoP countries, most of them which are also on the presentation today, are currently doing their own self-assessments, and I'm sure they will testify to some of the challenges in getting some of this data along the cascade. Moving on, one of the issues that was mentioned, I think the alternative sample types and other technologies to try and improve access to viral load. And point of care has been mentioned several times. And George here says, if point of care is not strategically placed and utilized, it will not support the scale-up. Other systemic problems affecting such scale-up, such as demand creation, supply chain, should also be addressed. There are some countries that are not using point of care, but are doing very well. So I think, so use of point of care is not a silver bullet. I think that's what he's saying. It requires that system approach in order to make sure that I think we achieve the goals. So thank you, George, for summarizing it in that way. I would like to move on and take on some of the questions that are coming through. And I see here Clement Piri is coming with also another interesting aspect of multi-disease testing. And he says, how will the use of point-of-care devices like GeneXpert for multi-disease testing affect viral load scale-up? Is it positive? Is it negative?
Well, ideally it would be, and Clement probably knows already the answer to this question he's asking, but ideally it should improve, because one of the things we need to be thinking about here is not just, and we're learning a lesson from SARS-CoV-2, it's not just focusing on HIV alone. And even our clients who have HIV have other, may have other pathogens as well to be concerned about. So we need to make sure that we are strengthening systems for infectious diseases. We're prepared for not just the current pandemic, overcoming it, but prepared for future. And so the way of the future is multi-disease testing. So absolutely, I think we need this, and it should improve. And it also should improve our aggregation of data collection and the quality of the data. We need it not just for, we built these platforms for HIV. We need to utilize the systems that we have strengthened for HIV to broaden it to other pathogens for a more holistic disease management process within countries.
Thank you. Thank you, Shirley. There is also another question which is coming from Jonathan Dang, and he says, what is the percentage of aggregate average data? What percentage of average data is plasma to viral load? To DBS for viral load. I think he's looking for, if I read this one correctly, how much of the DBS as compared to the plasma is being used.
Okay, so that is variable per country. We do have one country among these 8 that is using plasma completely. Most countries are using a combination of plasma and DBS. It makes sense to use the DBS to expand viral load testing, and particularly in hard to reach areas. For Lesotho, for instance, they're still trying to scale up the DBS in mountainous regions. It's an extreme challenge to get to some places where you actually have to even go in by horse. It's that challenging. You're not even going in by motorbike. That's just particular, that topography is just specific to that country. Other places are using more like 50-50. So it's variable for countries, and I think people need to use what works best. If we're looking at the U versus U, the plasma is very helpful, right? Because we can get down to a low number of copies to determine that U equals U. But most importantly, we want to make sure that everyone gets a test. And so DBS should be used and expanded in any place where it's needed so that we can get timely viral load testing. So it's variable to answer this question. It's not the same it varies by country.
Thank you, Shirley, once again. In your presentation, you indicated that overall, I think the countries were doing well. But when you now go into population subgroups, it may not be the same. And I'm linking this to a comment from Windini from Burkina Faso, who says, adult viral load is prioritized and there is less attention to EID. Scarce resources complicates the situation. And that's what she thinks.
Okay, so we always encourage, EID is another topic, but we encourage EID testing to be done first when when we have backlogs, for instance, which we have had multiple of those challenges, particularly since COVID. EID testing, the babies should be prioritized. And from the beginning, we stressed that EID should be prioritized. So I don't think there's any debate about the prioritization of EID. In some ways, it seems like we should have made more substantial gains with EID, given, you see this huge trajectory with viral load. So again, variable per country, but here is where I think when we were expanding point of care, and we're using EID testing for point of care at multiple sites, that makes a lot of sense so that we can get those results quickly. And, we want that to be done in a timely manner. And ideally, we'd like to see 100% by 2 months, but we're not seeing that. We are still seeing huge challenges. And what was the other part to the question? So my comment is that we agree with you. We need to prioritize that. Oh, and then some of the populations, you were mentioning that. We have some challenges with key populations not having the full coverage. We have difficulty with pregnant and breastfeeding women. So there are pockets that need targeted focus and targeted strategies and interventions so that we can improve those. So I agree with that.
Thank you. Thank you once again, Shirley, for that. And there are quite a lot of comments also coming into the chat. Jeremy, thanks a lot for sharing some of the experiences from the DRC. And he raises, I think, some of the points that you have mentioned in really strengthening the issue of demand creation. But most importantly, he says engaging the ministries of health will be very important for the successes of all this. Issues also, George says, countries should conduct DNO to fully understand, so DNO, diagnostic network optimization, to fully understand instrument footprints, testing capacities, and the needs for both conventional and point of care, so that we strategically place these diagnostics for the benefit of all the populations.
Well said. And I think for diagnostic network optimization, we've been encouraging countries to do that. over the last few years, and it's an ongoing thing. So in some instances where we did diagnostic network optimization and then we had COVID come along, we have challenges. We realized that we weren't, we need to continue that diagnostic optimization, and it needs to be, again, not just for HIV. It needs to be more of a holistic strategy for the country. And not just individualized, but we look at that as an ongoing process to continue to improve systems, to continue to strengthen specimen transport networks, all of it. And incorporated within that is also the data collection piece and how we do that, and making sure that we can get that information timely back to the ministry from all of our sites.
Thank you again, Shirley. There is another question that came from Anna Mailer. And it came directly. We encourage people to send questions to everyone. She says, Firelord done on DBS samples. Has there been any improvement for elution? I think it's the technical bit of it. And analyzed simpler. The elution phase mainly manually takes up extra time and maybe possibly is prone to more errors.
Yeah, I'm not aware that we have some quick and easy or better way to do that. We do have newer technologies coming on board, like the plasma separation card. And I know some countries have already been approached by the manufacturer. There's only one for that. So there will be other methods to use other than just using our traditional collection, looking at either plasma or DBS. The separation card offers that. I don't know if anyone else wants to chime in on that, on the best way for elution. If anybody wants to put that into the chat, and then Anafi, you could share it. But
yeah. Sure, thank you. I think if anybody wants to chime in there, I think we also once had a session on the issues of separation cards as well coming through. But we are happy to get more, I think, perspectives coming through. You can lift your hand. Ronald tried to ask a question. I'm not so sure which way it is, to which it is linked, but maybe it's probably around DPS. So I'll call upon Ronald if you are available to just come through exactly what you meant when you say, what's your take on strengthening collection, storage versus outcomes? We'll park that for now. A lot of interest in DNO, really, Kate, thanks for the comments, where she further says it is not a one-time activity. It is something that should be visited frequently to make sure that we are always efficiently operating our networks as things continue to change. For example, now we have COVID-19 changes all the dynamics of testing. And Pascal also says DNO should be routine network management activity beyond HIV programs. An important point indeed to link with also integration of diagnostics. I see quite a number of questions that came through, but some of them you probably have already addressed them. Raphael, in case I might have missed this one, says, this is an excellent presentation, so thank you, Shirley. As most countries start embracing U equal to U as a prevention access to campaign, and WHO cutoff of less than 50, more frequent viral load testing assures durable viral load suppression would be required. Additionally, unsuppressed patients with new cutoff as opposed to the currently used 1,000 would increase. How well are these countries prepared for this and the expected spikes in viral load needs? I think this is an important topic that I think gained momentum some bit of time last year in terms of cutoff for viral load suppression.
I'm looking at that as more of a comment than a question, but definitely we need to make sure that people are virally suppressed. The issue of making sure that you have U equals U feeds into the DBS issue, and that we need newer technologies that would allow us to get down to that low copy number for U equals U. I think, where plasma is convenient and we can easily do it, that's where we need to use it. South Africa is a country that primarily uses plasma, and they figured their system out. But what we don't want to do is to leave people out who are in remote areas. And DBS is very helpful with that collection process in villages and towns that are far away, and transport, which is easier and doesn't require cold chain. So I think it's a balance. We need that, but where it's not as feasible, then we need to scale up the DBS so that everyone can get a test. So ideally, if in the Western world, we use plasma primarily, but the systems are easier in terms of access. So there's a role for both, I would say. Plasma, where it can be done, obviously we can get that low copy number, but where we cannot, then we need to be using DBS so that everyone's included in getting a test.
Thank you, Shirley. I think those are important insights. And George says great response on the use of U and DBS and plasma. I think this also is an interesting point from the audience. I think Ronald has now clarified his question, still talking about plasma separation. I think this is the same point you were mentioning within the 6 hours, and the need to standardize. No, it's slightly different. I think Ronald is just sharing other best practices, which is what we also encourage in this platform. He is just giving the, I think, some of the pointers that it is important to watch out for pre-analytical processes, such as plasma separation within the required time, which is normally 6 hours, and to standardize centrifugation in order to make sure that the quality of testing is as important as possible. Moving forward, we are now looking at the 95, 95, 95. Sometimes they say the journey becomes more difficult when you are about to reach, when you are tired. How best can we continue picking up this momentum? I'm not only asking Shirley here. I see quite a lot of country representatives are there. I see people from Kenya, South Africa, the DRC, Burkina Faso, Malawi, nearly, I think everyone today is participating. So how best can we move forward? I think it's just an open question. Going once. Please feel free to just lift your hand and comment. Pascal says, in addition, we want to apply those good practices from Namibia, Kenya, and Lesotho to those that have not reached there. I think those that have already reached the 90s, how best can we reach there? I think that's an important question. Jeremy was asking, also, if I remember well, I can't see the question right away, but you were saying, how has POC helped, I think, specific groups? Do countries that are using POC use them for specific groups of the populations or for everybody?
Do countries use what for specific group?
For point of care testing. Do they use them for specific populations or for everybody? For PEPFAR, we are have expanded, and the WHO has, I think, a broader guidance on that. Maybe somebody from WHO wants to speak to the WHO guidance, but
we're expanding point of care testing beyond what we used to do for pregnant breastfeeding women and those failing therapy to the pediatric population. So that should help. The WHO guidance is a bit broader related to point of care. So there's a varying stance on that or opinion on that. I think it makes sense to use point of care where we don't have access to the conventional platforms. We do have some countries that have done an excellent job using conventional platforms to broaden coverage. But in other situations where it's difficult to get transport, for instance, it's difficult to get to where the main platforms are, then I think that we should definitely expand the point of care access.
Thank you, Shirley, for that. Eric says the last 95, I think he was responding to my question earlier on, is the clinic lab interface. That is the platform to also bank on, I think, to make sure that we are all working together. Fibion's hand is up. Fibion, please feel free to unmute and go ahead and make a comment. Fibion.
Hi, thanks, Anafi. Yeah, my question was more around, the issue around point of care testing and multi-disease testing, because, with COVID, and lockdowns and all that, people cannot travel. So I didn't get maybe a response around how we can really utilize, community testing and even multi-disease testing on the platforms that are already existing and push that forward to make sure that, we can reach, patients that need viral load testing, EID testing, COVID testing on the platforms that are already existing. Over to you.
Thank you, Fibion. Shirley, you want to attempt?
I'm sorry, can you repeat? I was reading in the chat a few things. Can you just repeat the question, please? Sorry.
Fibion, can you come again?
Can you just summarize the question for me and I'll address it?
Yeah, okay, sorry. So I think it was more around multi-disease testing that is available right now and the platforms that are already available in the countries and how we can sort of like utilize those to make sure that for viral load, EID, COVID testing, we are able to increase access without really procuring more machines and all that, because with limited resources, we do have limitations, right? So how do we really, like, within the countries, make sure that that is happening?
How do we make sure that we have multi-disease testing? I think that's a conversation that needs to be had with the ministries of health and the strategies that they want to employ for testing. But it certainly makes sense. It is a decision that the country needs to make, that they're going to go with that approach.
Thank you, Shirley.
Something I saw in the chat about some best practices. Okay, I'm sorry, the chat, there's so much in the chat, so I can't. Best practices, and I would say like for Lesotho, that's been like significantly, there's huge challenges, and they have done an excellent job at trying to overcome those challenges. One of the things has been like for backlogs, which did accumulate during COVID, and then broken equipment, broken down platforms, which the manufacturers and repair people could not get in to do it. They made a decision to shift specimen transport to the facilities that did have working equipment. So, I mean, that's one something that you can do when you can't, in the case of a lockdown or difficulty with getting things repaired, have a backup strategy for what you're doing, so that if lab X cannot meet the demand, then you can shift to lab Y and Z. And I think Kenya also had employed that process in the past. So shifting, and then training people you can do for multiple tasks can also be helpful, so that when you're stretched thin in one area, you can task shift adequately and have the personnel that you need.
And thank you once again. Very interesting discussions going also on in the chat as well, where Levi mentions that, you know, some of the best practices like targeted approaches through the clinical laboratory interface, QI initiatives, data-driven approaches could also be the way to go, particularly at the stage where we are right now. And Nancy responded also some of the things that they use, how they use POC in Kenya. They are using it in hard to reach areas. Eric had also mentioned the issues of dashboards also being used. So it's quite informative indeed. I know George had also entered quite a couple of comments in the chat. George, if you are available, you can also just chime in as we move towards the end.
Yes, good morning and good afternoon, everyone. I think this is one of the best presentations for this period, particularly in the context of COVID and the need for us to scale up both viral and early infant diagnosis. So Shirley, thank you so much for sharing that information. I think we've learned a lot from all the different strategies, but as we move forward, programs should really see themselves holistically and really migrate away from silo testing to the integrated diagnostics and multiplexing. And of course, moving towards the community, we're really getting out of this silo or centralized testing to the community-based testing, and also looking for strategies that can tie on with viral and infant diagnosis sample testing. So thanks so much. And I think it's been a great day for all of us. Over.
Thank you, George. Shirley, any quick last words? You are on mute, Shirley. Shirley, you are on mute.
Sorry, I'm sorry. I didn't realize I'm talking to myself here. No, appreciate George's comments. And I do think that we have learned a lot during this COVID pandemic. And I applaud all the countries for the work that they've done to really do what they can to rise to the occasion, to not decrease the gains that we've made with HIV while we still tackle this problem, which is ongoing. And we don't know how long this will last. I think that strengthening the systems that we have built on HIV, the specimen transport network, the data systems, you know, how to train people in molecular-based testing, all of these strengths that we have gained from work in the HIV epidemic, we can utilize those lessons learned and the strategies that we have used to be successful to move forward to tackle what we have to do today, and then what we don't know that will come down the road. So now is the time for us to, and the multiplexing piece is key, because we need to, you know, move beyond just the HIV. We have a lot of issues in our countries, and diagnostic network optimization for TB, for HIV, but for also for other pathogens, utilizing the same systems and strengthening those, and good data collection, which is key to knowing what we have and what we have accomplished and what we need to do, and use the data to inform decisions going forward. So those are and community engagement is key. I do want to strengthen that, to mention that, the key community engagement. Yes.
Thank you, Shirley. In closing, I think these are the same comments that Takudzwa, Machirori, and Pascal are making also in the chat there, that really is the collaboration of the teams and programs in order to share and optimize the current resources that we have. COVID-19 has significantly increased the cost of doing business, which has resulted in further strain in our resource-limited settings. But it can only be collaborative approaches between partners, the government, shared work plans, and ultimately the optimal use of resources that will see us moving forward. Thank you very much. It's been a wonderful session. I would like to thank all of you that came through and stayed until the end. Till we meet again, goodbye and have a good evening, good afternoon, and possibly good morning for those that are still in the West. Bye-bye.